My name's Andrew Pearl. I'm happy to be here on behalf of Biomet Sports Medicine. We're going to be talking about femoral tunnel positioning today. Dr. Steve Howell, Dr. David McAllister, and I have come up with an acronym to describe our optimal tunnel position, and that acronym is IDEAL. I'm going to get you oriented. This is proximal or deep. This is shallow in the notch or distal. This is low in the notch or posterior. And this is high in the notch or anterior. Dr. Howell and McAllister and I are not going to be talking about the AM and the PL tunnel position, but if you want to use that nomenclature, this is more of an AM region and this is more of a PL region. So I'm going to point out the different aspects of the ideal position. The I in ideal stands for isometric, and work going back to the 70s has shown that this deep and high position in the footprint is the most isometric. And in fact, the isometric region is this high position of the footprint. This lower position, or more posterior position, off the posterior femoral cartilage is anisometric, and you see up to 15 to 20 millimeters of length change in a graft as you take it through range of motion if you put the graft down in this region. So the I is for isometric. The D is for the direct fibers. Now this is a histologic description of the footprint. Sasaki has pointed out that there are direct and indirect fibers histologically in the ACL footprint. The direct fibers are higher or more anterior along the intercondylar ridge, and the low fibers are more posterior down here along the posterior femoral cartilage. Now you can't discern the indirect versus the direct fibers macroscopically. This is a histologic classification, but again, indirect fibers are in this region and the direct fibers are in this region down here. Well, why is that important? We recently did a study showing that the direct fibers, these fibers in the high region, take up 80 to 90% of the load during stability testing, i.e. the pivot shift and the Lockman maneuver. So we feel that these direct fibers are functionally more important than these indirect fibers. The E in ideal stands for two things. One is eccentric. We want our femoral tunnel to be eccentrically located within this footprint. This is a central position within the footprint, but we don't feel that that is an appropriate position for our tunnel. We actually want our tunnel to be slightly eccentrically located within the ACL footprint. The E also stands for equidistant. If you can't see the footprint anatomy, a simple way to find the ideal femoral tunnel position is to find a point that's equidistant between the top of the notch here and the bottom of the notch, adjacent to the posterior cartilage. If you take the point that's halfway between this top point in the notch and this bottom point here on the posterior femoral condyle, that point is somewhere here, right in our ideal position. So that's a good trick if you can't see the remnants of the femoral footprint. The A in the ideal acronym stands for anatomic. So this is the entire ACL femoral footprint. You can place a tunnel in this region and be anatomic, in this region and anatomic, or in this region and be anatomic. The point is that the footprint is so broad that there are many anatomic locations within the footprint. We choose an anatomic location, i.e. a location within the footprint, but one that's eccentric within the footprint. It's not dead center in the middle of the footprint. The L stands for low tension. We know this region of the footprint represents a region where an ACL graft will see low tension. This is work by Dr. McAllister and Dr. Markoff, and they've shown that grafts placed in this region of the femoral footprint experience less tension through the range of motion than grafts placed in this position of the footprint. Okay, I've skeletonized the notch a bit, taken the soft tissue off the notch, and I've caramelized the ACL footprint. So now you can see a little bit more clearly the entire footprint. It's almost oval or comma shaped here. And again, I'm going to go through the acronym. Let me get you oriented first. So this is deep, shallow, high or anterior, low or posterior. We want to be in the ideal position, somewhere in this region. Our ideal position will be isometric. We feel this is the most isometric region of the footprint. It's in the direct insertion. So these are the direct fibers of the ACL. These low fibers are the indirect fibers of the ACL. It's eccentrically located in the footprint. Again, a lot of people have talked about covering the entire footprint, and if you can't cover the entire footprint, going smack dab in the center of the footprint. We disagree with that. We want to be more strategic, and we want to choose the best fibers of the footprint to reconstruct. So we want to be eccentrically located in the footprint in a place where the fibers are isometric, where they see low tension, and they're the most functional. So this is this eccentric position. The other way of thinking about the E is equidistant. It's equidistant between the top of the notch here and the posterior femoral cartilage of the lateral wall. So equidistance between the top and the bottom here gets you somewhere in this ideal position. A is anatomic. Again, look at how big the footprint is. All this tissue is insertion site tissue, is footprint tissue. You can't cover the entire footprint with your tunnel and your graft, so you have to be strategic. We want to put our graft right here. And the L is low tension. We feel from David McAllister's work that this is a low tension region of the footprint if you put your graft in this region, as opposed to putting your graft centrally or even lower. You see high tension on the graft just through a range of motion. So I'm going to look back here. This is my back wall, and I'm going to use the electric cautery to mark my spots. So this is where I want to be. Note that I'm eccentrically located in the footprint. I'm relatively high in the footprint, in the direct fibers. I'm not smack dab in the center of the footprint, which would be right here. I'm closer to the back wall, and I'm moving more towards the intercondylar ridge here, and I'm moving away from the low position, which is adjacent to and bordering on the cartilage. So I want my tunnel to encroach on the ridge. The ridge is right here. So this is the precision flexible reamer guide system from Biomet. As you can see, it's got an angle to it, and it's got a foot which captures the back wall so that our tunnel does not blow out the back wall. It's also got two alignment options. One is coronal and one is trajectory. The concept here is that you want to line up the coronal guide with the joint line, and then the trajectory will show you an estimation of where your pin will exit the lateral cortex. Clearly, you don't want the pin to come too vertical. You don't want it to come perpendicular to the lateral cortex, and you don't want the pin to exit too low, which would suggest that you're going to have a very short tunnel. So we're going to use a medial portal technique, and we're going to use this precision flexible reamer system. The real advantage from my point of view is that you don't have to hyperflex the knee, and you can do your drilling and your reaming in 90 degrees of flexion. So as you can see, we've got the precision guide system. The foot I'm going to hook around the back wall here, which I've established using my curette. You can see where I marked my ideal position. And so now we're going to put a flexible guide wire in. I'm in 90 degrees of flexion, and I've got this back wall hooked. If you look at the alignment system, My coronal plane alignment guide is in line with the tibial plateau, and my trajectory guide looks like it's going to exit the anterior lateral aspect of the femoral cortex, which is right where I want it to be. Again, it's not too vertical like this, so it's not exiting perpendicular to the, so it's not exiting straight through the anterior cortex, which would suggest that I'm going to be too vertical with my graft. And the trajectory guide is not going too low and exiting very far posteriorly on the lateral cortex, which would suggest that I would have a short tunnel. Got a flexible guide wire that's coming in. Okay. And bullseye. So now you get a sense that we're in this equidistant position. We're about halfway between the top of the notch and the bottom of the notch, or the most posterior aspect of the lateral femoral condyle. You can also notice that our guide wire is exiting halfway between the anterior aspect of the femur and the direct lateral aspect of the femur. So it's an anterior lateral exit point. So now looking at our position, you can see we're eccentrically located within the footprint, but we are within the footprint. We're going to encroach on the ridge, which is the direct region of the footprint. The direct fibers live in this region. We should be isometric. We should have low tension through the range of motion, and we're definitely within the footprint. So this is the highest portion of the footprint, lowest portion of the footprint. So we're still within the footprint. We're still anatomic, but we're not dead center in the central region of the footprint. We can measure our intraosseous length with the depth gauge here. This looks like this tunnel. Our intraosseous length is going to be about 35. So we've got an 8.5 graft, a 8.5 millimeter diameter graft. So we're going to use an 8.5 millimeter flexible reamer, and I'm going to ream to a depth of 25. And we're at 25 now. So we're going to finish our tunnel with a 4.5 millimeter flexible reamer. And it feels like I'm at the cortex here. This should be 35 here. Going through the cortex. At about 38. So what you see here is a beautiful tunnel. There's a millimeter back wall. We're not dead center in the footprint. We're eccentrically located. We're still in the footprint. These are fibers of the footprint. So we're well within the footprint, but we're in the ideal position. We're in an isometric position. We're in this direct fiber region of the footprint. We're eccentrically located. We're about equidistant between the top and the bottom of the notch. Definitely anatomic, and we're in a low tension zone. So we feel that this portion of the footprint is functionally more important and better to reconstruct than this portion of the footprint, or even a central portion of the footprint. So we're going to use the Biomet tibial open guide. The guide pin will go through the center of this oval portion of the guide. And I've got it set for 55. And I'm going to try and put it right in that mark that I made with my electric cautery. Let's see where I am. Okay, now you get a more panoramic view. Why don't you drill? Panoramic view here. So there's the anterior horn of the lateral meniscus. There's my footprint. And a little bit on the medial aspect of the footprint, more towards the posterior aspect of the anterior horn of the lateral meniscus. So here's our tibial tunnel entering, again, on the back half of the lateral meniscus. in relatively a central region of the tibial footprint. Again, if anything, it's a little bit on the medial aspect of the tibial footprint, and I certainly try and not be too anterior. You can straighten the knee just a little bit. And when we straighten the knee, we see that there are a lot of fibers anteriorly. I don't want to come through those anterior fibers with my tunnel. So there's a good view of my position for a tibial tunnel. So we're going to use the Biomet toggle lock with zip loop. We've pre-zipped this zip loop to 40 millimeters. Our interosseous tunnel is between 35 and 38 millimeters. So we've pre-zipped it. We'll pass it, lock it on the lateral cortex, and then we'll dock the graft into the femoral socket using the zip loop technology. Go ahead and pull up. Okay. Good.
And snap. And snap.
Okay. So the toggle lock is on the lateral cortex. We're going to get the drawstrings for the zip loop. And now we're going to dock the graft into the femoral socket. Okay, so this is our final graft position. We can look at the isometry. Look at the suture here and note its relationship to the anterior horn of the lateral meniscus. We'll see how much length change there is through the range of motion. So let's go ahead and extend the knee. Not a lot. Couple millimeters or so of length change through that range of motion. So we know that we've created an isometric graft. We can predict that this graft is going to see low tension through the range of motion. We see very little impingement or no impingement as we bring the knee through a range of motion. I will often look at whether the graft gets abraded to see whether it's going to impinge on the lateral wall or on the roof. And as you can see, as we bring the knee through a range of motion, here there's no impingement. So we like this position very much. And that's our ideal philosophy and our ideal position for our femoral tunnel.